Thanks everyone for being here. Like I said, I know a few of us, or a few of the faces here I have met before. A few of them are familiar. Some of you I don't know as well. But we appreciate you coming and learning a little bit tonight with us. I'm going to give you just a brief little introduction. Just for a heads up, the topic for tonight is on this word up here. Doing okay out there? Yeah. Okay, perfect. Does anyone know how to pronounce that word?
Tinnitus.
There you go.
Pronounce it wrong tonight.
Tinnitus is easier.
Yeah, tinnitus is easier, I agree. Yeah, so truthfully, it doesn't matter too much how you say it. Technically, the correct way to pronounce it is tinnitus. It doesn't matter though. If you want to say tinnitus, that is fine. So tonight, that is the topic. We're going to be talking about things that we can do about tinnitus and how we can manage it. And I may just shut the door here just to eliminate some noise. But if anyone needs to leave at any time, you're okay too. Okay. So just a brief introduction. So my name is Dr. Josh Wicker. I'm one of the 4 clinical audiologists in our clinic. 3 of the 4 of us are very, very specialized in tinnitus, and this is something that we work with quite frequently. One of our audiologists actually has a little bit, well, just advanced education on the topic of tinnitus and managing it. I'm kind of in that process, but I have worked with tinnitus patients for a while now. This is kind of my jam.
Did you go to school in Miles City?
I did grow up in Miles City.
You did?
Yeah. Are you guys from there?
Well, we
Used to
lived
be.
there, yeah. I worked in special ed.
Okay.
And you're a twin?
No, I
No.
do have 2 brothers that are
They're the
twins.
twins.
That are
Okay,
younger.
I remember him. Okay.
Yeah, Jonah and Ethan,
Yeah,
you know them?
yeah.
Okay, yeah. Oh, cool.
Yeah,
Small
'cause
world.
when I went through the school system until junior high, and then here.
Oh,
So,
perfect.
yeah.
Very
Yeah, there's a
cool.
small world.
Yeah.
I kept thinking, that's not dad.
Yeah. Nope.
Okay. Now I know.
Yeah. So originally I grew up in Miles City, Montana. I moved away for school. So I was away for school for about 10 years and kind of missed being close to family and moved back to Billings. So I'm a little closer to my parents in Miles City now. This is a picture of my family from a year ago. And we had just had, you'll see the baby in my arms. Her name is Eleanor. You see my toddler there, his name's Luke. He's running around here with my wife. So, and then so we had these pictures taken in October and we ended up with a bonus baby in December that we adopted. So that's Lola at the bottom. We've got to get an updated picture of that. Thank you. But yeah, so as an audiologist, I specialize in basically all things related to ears and hearing. 2 of my main interests and specialties are in tinnitus and then something called cochlear implants, which is essentially something that we use for people who have really, a lot of trouble hearing. And we won't talk too much about that tonight, but. Oh, one other thing I was going to mention, let me go back. So our office, we talked about this with a few of you tonight. We actually have 2 buildings. So our other office where we're more audiology heavy is actually just right out here. This building we use for most of our therapies, so speech therapy and occupational therapy. Just a heads up, if you ever come to see us, we may end up seeing you in our other building just right there. So on the agenda for today, we're going to be talking about a few basics, and then we're going to progressively get a little bit more in depth. So we're first going to talk about the anatomy and physiology of the ear. We don't often think much about what happens with our ears beyond the weird floppy things on our heads. So we're going to talk a little bit more about that. We're going to talk about the relationship between hearing loss and tinnitus, and why that's important to understand. We're obviously going to be talking about tinnitus treatment options. That's probably a big reason why many of you are here. And then To kind of wrap it up, we'll talk about very specific options and why it's important to work with a provider who does this frequently in order to kind of find success with managing tinnitus. So first, anatomy and physiology. We're going back to school here. So how do we hear? So we're going to break down this diagram a little bit. Because like I mentioned, we often think about the big floppy things on our heads. And that has a very unique name. So this is what we call the pinna. And then inside of the ear is the ear canal. This is the thing we're technically not supposed to stick Q-tips in, but sometimes we do anyway. And then this blue thing right here is the tympanic membrane or the eardrum. It's not actually blue, but it's highlighted there for us.
Color coded.
Yes. So beyond the eardrum, we tend to think a little bit less about. So beyond the eardrum, we have 3 small bones. And actually there is a typo I meant to fix and forgot to, but the names of those bones are the malleus, incus, and the stapes. In grade school, we learned that they are called the hammer, anvil, and sternum. So the 3 smallest bones in our bodies. And kind of what happens is that eardrum vibrates with sound, and it vibrates the bones, and the bones convert those vibrations into energy that is interpreted through the nerves, which we'll talk about in a second. There's also this tube that we call the eustachian tube. So this is basically a tube that goes from our ears to the back of our throats, and it helps drain fluids and equalize pressure and that sort of thing. So in the next section, we have a very, very strange shaped organ. It's actually a couple different organs that are all interconnected. So we have the semicircular canals, which is part of what we call the vestibular system. We could have a long talk about what those do. Basically, they help us with our balance. And then the little snail-shaped thing there is called the cochlea. That is basically the organ of hearing. So this is the way that sound gets transmitted from the vibrations of the bones. Those vibrations get carried through the cochlea and then sent through the nerve, which isn't highlighted here, but it's right where that yellow line is. The nerves go to the brain, and that's where the sound is sent. Beyond that, it gets a little bit more complicated. So there's not a ton here that we really need to know, unless you're really nerdy and want to know a lot. But basically, the point of this slide is to show that beyond the cochlea, there's nerve pathways that go through the brain, and there's important road stops along the way, and each of those road stops help with a particular aspect of how we process what we hear. So your brain is making sense of what we hear, but your ear is what collects what you hear. We're going to kind of come back to this in a minute, but there's a very specific organ called the cochlear nucleus, and it's located within the brainstem. That one is going to be important for our understanding about tinnitus, so we're going to come back to that. But just remember that name, cochlear nucleus. So we're going to watch just a 2-minute clip that illustrates how sound goes from the ears to the brain, just to kind of summarize what we're talking about.
Have you ever wondered how sounds make their way from the source all the way to your brain? Take a trumpet, for instance. When it's played, it makes sound waves in the air. The outer ear catches the waves, which then travel through a narrow passageway called the ear canal. The sound waves reach the eardrum, which is a membrane roughly half the size of a dime. They make the eardrum vibrate, which in turn vibrates 3 tiny bones called the malleus, incus, and stapes. These bones amplify or increase the sound vibrations and send them to the cochlea. The cochlea is shaped like a snail and is the size of a garden pea. It is filled with fluid, and the sound vibrations make this fluid ripple, which creates waves. Hair-like structures called stereocilia sit on top of hair cells and are grouped together as hair cell bundles inside the cochlea. The hair cells inside the cochlea ride these waves, and the hair bundles are moved. The hair bundle on top of the hair cell turns these movements into electrical signals. As the hair bundles are moved, ions rush into the top of the hair cells, causing the release of chemicals at the bottom of the hair cells. The chemicals bind to the auditory nerve cells and create an electrical signal, which travels along the auditory nerve to the brain. Different hair cells respond to different frequencies of sound. The hair cells at the base of the cochlea detect higher pitched sounds, such as a piccolo or flute. The hair cells toward the top of the spiral detect progressively lower pitched sounds, such as a trumpet or trombone. At the very top or apex of the spiral, the hair cells detect the lowest pitched sounds, such as a tuba. The auditory nerve carries the electrical signal to the brain, which interprets the messages as sounds that we recognize and understand.
Okay, perfect. Hopefully that made sense. Okay, so next little segment here, we're going to talk about the relationship of hearing loss and tinnitus. So we're going to have just a really, really brief lesson on hearing loss, and I'll kind of explain why in just a minute. One of the things that's important to know is that there are certain types of hearing loss that are they're correctable. We can manage them with medications or surgery. We can totally restore hearing back to how it should be. And there are types of hearing losses that are not as correctable or not really feasible to surgically or medically correct. And depending on if you have hearing loss and ringing in your ears, depending on what's causing those problems, that would suggest whether there's a likelihood that we can potentially fix the source of the problem. So the first type of hearing loss I want to talk about is what's called conductive hearing loss. So conductive just refers to a problem with one of the mechanical structures of the ear, so the eardrum or the bones. So a few examples would be if you had a perforation in your eardrum, if you had chronic ear infections, if those bones became disarticulated, or if they became really scarred up and didn't move like they were supposed to. Those things can, in theory, be fixed. The hearing loss can be restored in a lot of cases, and the tinnitus can be taken away. In this other type of hearing loss, it's called sensory neural. It has more to do with the either the nerve or the hair cells inside of the cochlea. These ones are not as fixable in the medical sense. There are still things that we can do to treat those things, but it's important that we kind of figure out what's going on if somebody does have tinnitus and hearing loss so that we can appropriately make recommendations that are helpful. So this gives an example of what the hair cells are supposed to look like in a simplistic view. And when these hair cells, if they get damaged, like what can happen from noise exposure or from certain medications, then what happens is the nerve fibers that are connected to those hair cells, they're still seeking input from your ears. The brain is still looking for information that you're hearing. The hair cells are not doing their job, so nothing is coming back. And so what happens is your brain creates this sound to fill the gap for where those hair cells are not doing their job. So you get this pleasant buzzing or ringing or hissing that doesn't go away. So like I said, we'll talk a little bit more about that, but just to give an idea of the different types, and there's also combinations of types of hearing losses, but these are the two main types.
Is one more common than the other?
Yes, good question. So the sensory neural is by far the most common. So the one that's a little bit more complex to deal with. But there are things that we can do, and we'll get to that. So an interesting thing happens. I've had patients that have come in with the concern of just tinnitus. My ears are ringing, it won't go away. It started recently, it's really bothering me. And so we kind of talk about those things. And then one of the questions that I ask, because they are related and it gives me information about what may have happened, is do you have any problems hearing as well? And sometimes I'll get the answer that no, I don't have any problems hearing. It's literally just the ringing and buzzing. And sometimes that is true. We can do testing and we find that the person has totally normal hearing. We're not seeing any signs of damage. And so we start looking at other possibilities for what may have caused it. But in about 90% of cases with tinnitus, we find some level of hearing loss. And one of the interesting things is that I think not a lot of people realize, when we do just a basic hearing test, we're looking at a chart that looks at specific frequencies. And if you count the numbers of symbols here, the red circles are for the right ear, the blue X's are for the left ear. There's 1, 2, 3, 4, 5, 6, 7, 8. So 8 per ear. We're only taking 8 data points of an entire frequency spectrum. So this typically gives us enough information about how you hear that we can manage that. But it also means that if we don't test between those frequencies, or symptom of an underlying problem. I have heard all kinds of things in terms of what people experience. The most common that I typically hear is that it sounds like ringing, buzzing, hissing, static. Some people say cicadas even. I've had a few people tell me that they hear Christmas music all the time. My wife would love that. I would not. But there's a lot of variations of what we consider tinnitus to be. And to give a simple definition, tinnitus is essentially a sound that you hear that is not physically present. There's also a kind of a subset type of tinnitus called somatic tinnitus, where the ringing or buzzing might only happen after loud noise exposure, but it will stay for a long period of time, or even from fairly low levels of noise. Or tinnitus that is prompted by movements of the jaw, head, or neck. Sometimes with this type of tinnitus, we find that there's a medical reason, like a growth or an abnormal anatomy in terms of like the vasculature around the ear that can cause some of those problems. But it's important that we distinguish that, because that has a totally different treatment realm of possibilities. So we already talked about this. 90% of cases, tinnitus is a result of hearing loss. So tinnitus is secondary to a hearing problem. Noise trauma is a really common thing, especially here in Montana. I work with a lot of veterans and individuals who work in just noisy environments with loud machinery, motorcycles, lots of shooting guns, all of the fun things in life. There are medical conditions, things as simple as earwax, all the way up to things as complicated or invasive as what's called an acoustic neuroma or a vestibular schwannoma. There's certain types of tumors that we look for. We want to make sure to rule those out. Those are very rare, but they do happen. There's also something called Lenire disease, which has something to do with our balance system and our ears. So we get dizzy and we have tinnitus as well. And then there are other things too that we might not think about, like even just, I mean, this is a broad spectrum, but heart problems, strokes, history of stroke, thyroid disease, certain medications can cause tinnitus. And sometimes even just changing to a different medication can help reverse that. Surgery, stress levels, poor sleep, multiple sclerosis, temporomandibular joint disorder, if you have problems with your jaw joint. So there's a whole bunch of things. So we're gonna go back to that, the name of that organ that we talked about. Does anybody remember what it was? There you go. Yep, you got part of it. Yeah. Yeah, there you go. You guys have done well. So the interesting thing is, and I think this is genuinely very interesting, but decades ago, there are research studies that have been published where patients went in and they had really, really debilitating tinnitus, and they asked an ear, nose, and throat physician. They were desperate enough, they said, let's just sever the nerve. I don't want to hear anything. And so what happened was they severed the nerve in a few of these case studies, and afterwards the patient still heard the ringing. So what we learned from that really important study is that even though these are really important organs for hearing, it also tells us that if we cut the nerve right here, if we're still hearing the ringing, that tells us the ringing is not originating from in here, it's somewhere up along that pathway. And what current research suggests is that it's happening in what we call the cochlear nucleus. That's not super important to know, other than just understanding that your brain stem is responding to a problem in the auditory system by creating a sound from that organ, but it's not necessarily coming from the ears. Yeah, so not coming from here, it's coming from up there. So and we're gonna dig into this a little bit, but when people ask, is there a cure for tinnitus? The truth is that not really. Like in theory, if we were able to isolate just that organ within the brainstem, or there's another organ we'll talk about in a bit, that yeah, maybe we could totally cure it. But the problem is that that opens doors for other problems that we could have that are necessary for our survival. So it's not a great cure. There are things that we're going to talk about tonight that we can do to treat it, and we'll talk about what that means and why that's important to understand. But yeah, we'll dig into that. So another organ that we're going to talk about, again, kind of going back to anatomy and physiology. So when we have tinnitus, there's kind of this question of, why am I so bothered by it? We have probably all heard from somebody, if we have tinnitus, we've probably heard from somebody else, oh, I have that. It doesn't matter. Why are you so bothered by it? Now, one of the problems is that some of those nerve pathways that we saw on the previous slide, they cross through what's called the limbic system. And the limbic system is responsible for reacting to things that we are stimulated by or things that are happening in our environment. So, and there's specifically what's called the amygdala. This is something that's really deep in the brain that is very, very important. That is the main job of the amygdala, is interpreting information that we process and classifying it in some way or processing it in some way. So to give you an idea, to really narrow it down and put it simply, anything that happens to us, the amygdala is trying to categorize as this is bad, or this is good, or this is neutral. So this is a really important organ for our survival. You can think about thousands of years ago or hundreds of thousands of years ago, from a survival standpoint, if you wake up and you hear a bear, you know you gotta run. And even now, if you're out camping in the woods and you hear a bear, that thing's gotta work so that you know what to do. Otherwise, your brain doesn't process it as important. On the flip side of things, if you hear somebody sing you happy birthday, or a loved one calls you and says, I love you, that generates a really positive reaction. So there are other things that are neutral. So like the fact that I think most of us, maybe not all of us, but if you're wearing socks, you don't think about that at all. It's processed as this is neutral, it does not matter, we don't need to take up any brain capacity in thinking about this. So to dig into that a little deeper, the brain, when we have tinnitus, especially when it's something that has recently come on, your brain is really good at identifying that as a bad thing. So you hear the ringing or you hear the buzzing, think, oh my gosh, what is this? Why is this happening? Is this going to be forever? And it produces this cycle where you start thinking about it more, and then you hear it more, and it feels like it gets worse and worse. When it creates feelings of fear, danger. I've had patients come in and they say, I'm scared that I have a brain tumor. Why do I have this ringing in my ear? Or what's wrong with me? Why is this happening? This never happened before. So in theory, if we're able to somehow break the negative feelings that are associated with the tinnitus, and sometimes this is easier said than done, but if we can interrupt that feedback loop that's happening, that is one of the first steps that we have to take in managing the tinnitus and stopping it from getting worse. If we can, and there are ways that we can do this, but if we can reclassify the tinnitus not as negative, put it in a neutral box, that's kind of where the magic happens. And we know that that's feasible because what the statistics show are that there's about 50 million people in the United States that have tinnitus. It's about somewhere, the research suggests somewhere between 10 and 20% of those individuals, it bothers them enough that they go see a doctor about it or talk to somebody about it. So we know that it's possible to be in that group where you have it, but it doesn't take up any impact on your day at all. We just sometimes need some help moving from one place to another in the statistics. So we've probably all felt some of this to some degree or some aspect of this, but tinnitus, and I want to just clarify that we know that tinnitus is not just all in our head. It's not something that your brain just creates or that it just makes up. Like we talked about, there are reasons that it occurs. There's both physiologic reasons that we might have it and also psychological reasons why it may impact us more. But some of the things that we know from research that it causes problems with are sleep, mood, concentration, mental health, sometimes relationships with others and wanting to socialize with other people. It can negatively impact all of those things. And the interesting thing is that a lot of these, if we are having negative impacts on those, it creates a whole other feedback loop. Like if you're not sleeping because all you're hearing is ringing at night, you're not going to sleep well. Your ringing is going to be worse in the daytime, and then you're going to be thinking about it and stressed, and it just snowballs from there. So is there anything we can do? There's a lot of information on this slide. Really, the point that I want to make here is the source of the problem, we may or may not be able to control. We may not be able to reverse damage that's been done to the auditory system. In some cases we can, in most cases we can't, but all of these other things here that are involved in that, whoops, sorry, I was trying to get it to go back. So all of these other things are things that we can address or adjust or manipulate in some way with the right tools. And so by altering our emotions, or altering the way that we subconsciously think about the tinnitus or perceive it, there are things that we can do to improve the tinnitus that we have. So what I tell patients is that you can think about tinnitus like a bee that's just buzzing directly around your face all the time. That is super annoying. I have bees that I was just out fishing last weekend and this bee just kept coming back right around my head and I couldn't get rid of it. So we may not be able to totally squash the bee if you have tinnitus, but we can force it way out into the background so it doesn't impact you in any way. It may be near, but if the further we can get that bee, the better. Okay, so now we're going to talk about the fun stuff. This is the treatment options. We're going to talk about research and what we know can work. We'll talk about a few things that we know may not work as effectively. So I'm just curious, what are some things that we have been told that can help with tinnitus? What have you guys seen online or been told by other people?
Fix.
Vicks, okay, nothing, yeah, I've heard, yeah, I hear that a lot.
I can never do so.
Classic, he said nothing, nothing can help, yeah. Eardrops, okay. I've seen a lot of CBD gummies or supplements that you have to pay for a subscription and,
I see some shoot up your nose.
okay, yeah, okay. So yeah, the interesting thing is if you look online, if you Google tinnitus cures or tinnitus treatment, you will see all kinds of stuff. I've seen tapping tricks on the back of your head and putting a water bottle over your ear and ear candling and there's a lot of stuff.
Is that a full water bottle?
A full water bottle, yeah. So we're gonna talk about some of the ones that are research-based, and then I'll tell you, and maybe let me talk about these ones first. So there are ones that don't have very strong research to support them, but I'll tell you that I've had patients that have told me my tinnitus was really bad until I started doing X, Y, or Z. So some of those things would be like acupuncture. I've had patients that have done chiropractic work, especially around their head or neck. Sometimes there's tension that can build up, especially with that somatic tinnitus we talked about. Sometimes things like that can be helpful. Again, the research is really not super strong in those areas, but I've had enough patients tell me that those things have been helpful that I recommend at least trying them. If it doesn't help, then you've tried it and you can move on. I'm going to focus a little bit more on the things that we know can actually help. So the first thing is something we call TRT. This stands for tinnitus retraining therapy. This was the gold standard. It has been the gold standard for treating tinnitus for decades now. So it is a form of treatment that uses two different modalities. It uses what's called sound therapy, which we'll talk about, and also counseling together. And it's a program that was developed by a really, really intelligent audiologist who is very old now, but very, very well known, very well respected. His name is Jostrabov. So this is something that we've kind of seen as the gold standard for a long time. What the research suggests is that somewhere between 70 to 80% of patients that go through this find really meaningful, significant reduction in their tinnitus. So very effective, very, 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 very safe. The other thing, this is one that not a lot of people realize, but if you have hearing loss in conjunction with tinnitus or tinnitus that is secondary to hearing loss, and I would say specifically hearing loss that is not medically treated. If we find you have hearing loss that can be medically treated, we're going to do that. That's going to fix, in theory, that could fix all of the problems. If you have a sensory neural hearing loss that's nerve related or related to damage to the hair cells, we start considering hearing aids. Depending on the research article you look at, the success rate for treating tinnitus with hearing aids is somewhere between 60 and 75-ish%. I've had a lot of patients that have said that this has been the thing. I actually just had a patient today that we tried a different option that I thought was going to be more effective for him. And he ended up going with hearing aids instead and felt like they were much, much more helpful for him. And so he has hearing aids now and feels like it really positively impacted his life. And then, whoops, getting ahead of myself. So counseling is the other one. So I I've had a good number of patients that if we start to see signs of just general anxiety or depression, and those are things I don't diagnose, I'm not a mental health professional, but if we see evidence that that might be present, there's quite a bit of research that suggests if we have them involved with a mental health specialist that focuses on cognitive behavioral therapy or CBT, that can help reduce the perception of tinnitus so they're not as aware of it. And realistically, this is treatment that almost anybody could benefit from no matter what issues you might have. So it's kind of a good all-around recommendation. I make fairly often, but especially if I see that we have a patient that's really, really, really anxious and having trouble kind of managing that side of things too. Because if we got a bunch of anxiety that's unmanaged, that's feeding that feedback loop that we talked about, and that's going to make it a lot harder to treat the underlying problem. And then lastly, this is probably the thing that most of you are here to learn a little bit more about. So there's something new. This is kind of the big new thing in the tinnitus treatment world. We call it bimodal neuromodulation. There's a very specific device we're going to talk about called Lenire. So what it does is it takes kind of the previous gold standard of tinnitus treatment, which is sound therapy, and it combines it with a whole other type of essentially therapy that is used for patients with tremors, phantom limb syndrome, other seizures in some cases. So we use electrical stimulation to treat some of those things. And so this is kind of the big new thing, using sound therapy plus electrical stimulation. We see really, really positive results. We'll talk a little bit more about some of the studies, but what we're seeing from the studies are that somewhere between 83% and 94% of patients that use Lenire for their tinnitus find that it's successful and beneficial. Any questions so far before we move on to Lenire specific?
Back up just a moment.
Yeah.
Tongue pressure or something there. Tongue pulses.
Yeah.
That's on them a bit.
Yeah, so I'll show you. Yeah, we'll show you what that means. Yeah, but it essentially electrical stimulation through your tongue. I know it sounds kind of wonky, but yeah. Yeah, no problem. So we're going to talk specifically about Lenire. And I want to preface by just saying, when we see patients, there's never a point where I think, before I even see them or evaluate them, this is the thing we're going to do. Like, it really comes from evaluating and figuring out, number one, what the cause of the problem is, what they've tried in the past, making sure they're medically a good candidate for whatever we recommend. And that kind of narrows down what our options are and what we recommend. We're talking specifically about this because this is a new device that received FDA approval in 2023, so it's only a couple of years old. And this really is kind of the big new thing in the tinnitus treatment world, so not a lot of people know about it. There are things that we'll talk about that would make you not a good candidate for it, and there are things that would make you an ideal candidate for it. We'll hopefully explain a little bit more in detail. So like I said, this is the only medical device that is FDA approved. I have a whole other presentation if anyone is specifically interested in this side of things, but talking about the research behind Lenire. Like I said, there's a lot of stuff you'll see on the internet, and a lot of it does not have any real medical basis to it or any research basis to it. This is one thing that genuinely does. So there were 3 research trials with a total of about 600 patients that have undergone treatment with Lenire. And the results were good enough that the FDA approved, so they gave their stamp of approval, saying that it is effective and it is safe. You can kind of think of it as kind of like a CPAP, but for your ears. So it's a medical device in that way. The one major difference being that this is something that is not, you don't have to use it forever. It's actually a short-term solution for managing tinnitus. So that's kind of nice. It's something you do have to use for a short period of time, but eventually the hope is to get off of it. It's a lot, and I'll tell you. So one of the issues that we have right now is that there is nothing else like it. So there are no codes to present to insurance. So all those other things we've talked about, insurance covers a lot of those things. This is so new that there is really just one exception to this, but insurance doesn't cover it. It's a little under $5,000. If you're a veteran, the VA has approved Lenire for tinnitus treatment, and we'll have to talk a little bit more about that because that requires some special approvals to get from the VA, but they have given the overall approval to cover it for veterans. Just know that even if Lenire is not feasible right now, there are other, like we talked about, some of those other solutions that we do where insurance can get involved. And the hope is that over time, there will be insurance approval.
So is there like a trial period that you
We'll talk about that. Yes. What was that?
would?
Yeah, no, that's okay, that's okay. So just to make sure we understand kind of the basics really quick. So it's a medical device that there's 3 different parts. So this first part is what they call a tongue tip. It's basically a tool that we deliver electrical stimulation to. So it's something you put on your tongue, and it doesn't shock you, but you feel really, really mild pulses of energy. It kind of feels like Pop Rocks candy if you've ever had that, kind of tickly feeling. There's a controller that controls the tongue tip stimulator and the headphones. And then the headphones deliver what's called sound therapy, which we talked about was kind of the previous gold standard for tinnitus treatment. Little side note, we could get pretty far in detail on this, but one of the studies that Lenire did was they reviewed success from just using sound therapy with headphones versus sound therapy with the electrical stimulation. And there was a really, really marked difference in success. Having both of them was much more likely for success than just the sound therapy. So kind of just an interesting thing there. So how does it work? Sounds kind of frou-frou probably to, I know, just for context, when I had heard about Lenire, I was actually in audiology school. I was in my first year and I saw an article, and I forget which journal it was, but there was an article that said, treating tinnitus with your tongue. And I clicked on it and I thought, that sounds ridiculous. And reading into it, I was able to learn a little bit more about how that actually makes sense physiologically. And kind of the idea is with the headphones, we're stimulating the auditory nerve. So you're getting some level of stimulation to your ears. But there is a nerve, it's a branch of the facial nerve that goes through your tongue. And by stimulating that other nerve, it allows your brain to essentially retrain itself if you have multiple modalities of input. So the tongue was used because, and this is from what I understand about the science behind Lenire, with things that we eat, we often have really, really pleasant experiences like, oh, I love tacos. It's one of my favorite things. Or I love the Tonight Dough Ben & Jerry's ice cream, one of my favorite things on the earth. So we have these really positive associations with some of the things that we taste, and we can make use of that sensory input to help retrain the brain with the tinnitus. And it turns out that it's actually pretty effective. So kind of the main thing that you need to understand is that it's bimodal. So there's 2 sensory inputs, one through the ears, one through the tongue, and that we have better likelihood of retraining the brain by using at least 2 methods of thinking. We're going to watch just a really short clip on what Lenire is.
Lenire binaural devices uses dual mode stimulation to soothe tinnitus. But what exactly is tinnitus, and how does dual mode stimulation treat it? Let's start with the brain and how it responds to stimulus. Repeated exposure to sensory inputs such as sight, sound, and touch strengthens or opens new brain connections. These connections are also known as neural pathways. As this occurs, other neural pathways can become weaker. These changes are known as neuroplasticity and are essential for learning and development. Playing the piano is an example of positive neuroplasticity. At first, playing the piano can be difficult. Regular practice repeatedly exposes the brain to sound, hand movement, and visual sensory inputs. This reinforces piano playing pathways and can lead to better playing over time. Tinnitus, commonly known as ringing in the ears, can be a result of negative neuroplasticity. Hearing loss can cause the brain to compensate for a loss in a sensory input. The brain then creates a new sound pathway to replace the loss of sound, even when there is no external source. This is otherwise known as tinnitus. Many people with tinnitus will try sound masking to get relief. Sound alone can activate pathways to temporarily distract from tinnitus. However, adding a second sensory input keeps the pathways active for longer and in a stronger manner. Lenire's dual mode stimulation combines two sensory inputs, sound stimulation and multi-pattern tone pulses, to activate hearing and sensory pathways. This dual mode approach weakens tinnitus pathways and helps the brain to stop focusing on tinnitus sounds. Tinnitus will still be present, but the brain will become less sensitive to it, which can dramatically reduce the impact tinnitus has on a person's overall quality of life. Learn more about the Neuromod's scientifically proven tinnitus treatment device, Lenire, by visiting www.lenire.com. Lenire. Soothe tinnitus.
Hopefully that clarifies a little bit of what's actually going on with this device. And then, so I just have a couple more slides I'm going to go through, and then we're going to take questions all about anything from Lenire to tinnitus to other treatment options. And so I want to make sure everybody gets their questions answered. So this data is actually a little bit outdated now. Still important to know though, so I kept it here. So from the 3 clinical trials from Lenire, what they found was that in their over 500 participants, that about 83% of the participants recommended Lenire. Keep in mind that for the FDA trials, kind of how those processes work is we have to, so the company that developed Lenire, they have to make sure their device is doing what they are claiming that it can. So there's no other factors in this study. There's no like an audiologist who helps coach and explain and do some of the informational counseling or provide other recommendations simultaneously that leads to better results. It was literally, here's your device, here's your instruction sheet, go home and do it, and we're gonna follow up with you every 6 weeks or so. So the data that we have now actually comes from real world clinics. There are really, really well-known, reputable tinnitus research centers in Colorado and Denver. There's one in Minnesota and one in Alaska. So they have also published their data from the first 2 years of release since the device came out and was approved by the FDA. And this is where we start to see some more of the higher success percentages up into the 90s. Another thing that's important to recognize that so 7 out of 10 people on average after just 6 weeks had more improvements with Lenire than when we were using just sound only. So like I said, sound only we know is effective to some degree, but we now have data that shows that Lenire is more effective than that. And then the really, really important one on the end there is that from the 3 clinical trials, there were 0 reported adverse long-term reactions to the device. So we know that it's safe. When the FDA evaluates medical devices, they give it a classification in terms of the risk level associated with it. There are some drugs and some treatment options that have some level of risk, and we have to kind of outweigh as it work the risks. The risk rating that they gave Lenire was very low risk for adverse reactions. So we can pretty confidently say that it's safe.
You said long term.
Yeah.
Is it short term?
There have been reported short-term implications. So there were, and I forget the number, we could look into it and let you know, but a very, very small number of patients have reported like sensitivity of their tongue, the pain, or there were a couple that they had really, really minor sores that went away after they discontinued the device. What they found was that the patients were allergic to the metal that was used in the electrodes. So that's something we handle really seriously. I personally have never seen that in our practice, but if something like that happened, that's something that we would take care of appropriately. That has to be reported to the FDA, and the company that develops Lenire takes that really seriously. So, in terms of any other side effects, the one other one I was going to mention is quite a few patients reported that their tinnitus fluctuated a little bit while on the training or on the treatment. But when comparing beginning to end, so prior to starting treatment to afterwards, almost, well, like we saw 83% to 88% is what the newer studies that were published had improved tinnitus. There was no one that had worse tinnitus at the end. So while they might have some fluctuations kind of in the middle, and usually more in the beginning is where we see that, by the end there was nobody that had worsened tinnitus. It was either better or it wasn't. Just to give you a little outlook on what the treatment process looks like. So it's designed to be an at-home treatment. There is a little bit of follow-up that happens in our office. So we first do a hearing and tinnitus assessment. We want to make sure that we are not running into any contraindications where it would be unwise to move forward with Lenire. If everything looks good and you look like you're a good candidate for Lenire, then we fit you with the device. We calibrate the electrical stimulation levels and the sound levels based on your hearing. Then you go home and you use it, and about typically we see patients back at 2 weeks, 6 weeks, 12 weeks, and then 6 months and 12 months. So there's quite a bit of follow-up within that year time frame, and we tell people that we expect you're going to be using it for at least 3 months, potentially up to 12 months for the entire course of treatment. So you follow up with me, we make sure that things are going well. If we're running into some issues, we adjust, and we're able to make some adjustments to how the device is programmed. But ultimately, most of the work is done by you at home.
How much time does that involve?
Yeah,
Having
good question. Yes, it is time invasive a little bit. So what Lenire recommends is about an hour per day. So yeah, and what most people are doing is they're breaking it up into 2 segments, one 30-minute session in the morning, 30-minute session at night. So this is one of the things I talk to my patients about, that if you don't think that's possible with your schedule, I don't want to mess with it, because it's not going to be helpful if we can't really consistently do the treatment. If you feel like that's feasible, then we may start looking into it. But yeah, it does take some work. There's a little bit of time involved there. So on that note, the keys to successful treatment, really the biggest indicator of success with Lenire is if you keep doing it. You gotta be super consistent. It's okay to miss one here or there. Like if you're out traveling and just couldn't get to it one night, that's okay. That's not gonna make or break anything. We don't want where somebody's only doing it a few nights a week, or it's really hit and miss. That doesn't work out. So it's good to have a routine. It's good to add it to your schedule, to kind of journal along the way. They recommend that you don't take breaks, like try to just get your session done and then carry on with your day. But there are certain things that the developers of Lenire suggest. Kind of the general idea is we want you to do things that are not stressful. So we don't want you answering work emails or watching the news. It's got to be things that are helping maintain the calming, the calming effects of what Lenire does, and then typically that results in better success. So typically reading a book, doing Sudoku, doing puzzles, I have a few patients that they have like morning studies that they do, and they just do their Lenire while they're doing their studies. And, there's a whole bunch of things we could talk about, but things that are calming, that are not gonna exert you physically and, or that will stress you out. Some things to avoid. So they don't want you driving while you're doing it, because you gotta be focused while you're driving, so that's just a safety issue. I've had patients ask me if they can use it in the hot tub. I think that sounds amazing, but you probably don't want to use an electrical device while you're in the water. So don't use it when you're in the bath or shower. Don't use it while you're walking in the rain. They recommend that you don't drink during your treatment. You can still drink afterwards or whatever. And they also don't want you to fall asleep while you're doing it. So you gotta kind of stay awake for it to be effective. Yeah, otherwise I would have no problems. But yeah, like we talked about, we kind of want it quiet and calm, just relaxing. Try to avoid technology if you can. Like I said, no work emails and distractions. They recommend setting up some mood lighting, just promoting the relaxing aspect of this whole thing. You don't want to be doing it in a really messy place where you're going to be stressed about the mess. So those are some good little guidelines that they do.
So you wouldn't advise trying an alcohol going for a bike ride?
No.
Probably not. I think, are you talking like motorcycle? Yeah, I think the main problem there would just be the noise of the motorcycle interfering with what you're hearing in the headphones. And also just the safety aspect of, we want you to hear your surroundings. Yeah. Good question. So we're just about done, I promise. So thank you for bearing with me. So a few frequently asked questions. We talked about this a little bit. Should I become worried or should I be concerned if my tinnitus worsens? I would say most people that have tinnitus notice fluctuations, and we can tie some of those fluctuations to certain things, and sometimes we can't. Some of the things that we have a little bit of research to support is if you've had really poor sleep, if you've had a bunch of sodium or caffeine, sometimes it can fluctuate and cause a little spike in tinnitus. I kind of expect that mainly during the beginning part of treatment with Lenire, you will probably experience a fluctuation or a few. That doesn't bother me because we know the potential impact by finishing the treatment is worth some of those fluctuations. But I kind of think of it like working out. When you start working out, if it's been a long time, you're going to be sore at first. And you're stimulating nerve pathways in a way that you probably haven't before. So there is a possibility that you'll notice it a little more primarily in the beginning. Again, I have not seen any patients where they've had it worse permanently. And with the FDA, there's been no reported data of that either. So it's really, really very unlikely that you would have it prolonged. You may notice fluctuations. I've never had a patient tell me they've had ear pain from it. That's something I want you to let me know, though. That's something we would take really seriously. But they're just headphones. So if you've worn headphones comfortably before, I wouldn't worry too much about that. I've had a couple patients tell me that they've had headaches, but unsure if it was related to the treatment or not. That's something else I want you to tell me if you were noticing. We would take that really seriously. And this is something that we would maybe do some modifications and see if it's related to hydration or stress or sleep and those things. We'd also get your primary care physician in the loop too, just to make sure we're not missing something. But it's not something I see very often. This is one I have not personally seen, but I have heard of record of a few patients that have reported this. So if the tongue tip, if the stimulation levels are set too high, there's potential that it could cause some discomfort. If you started noticing that, kind of the idea is you would let me know, and we would make sure that it's not an allergic reaction, which again, I have not seen. But we can reduce the stimulation level so that we're not running into that. Kind of the same thing, if your tongue feels numb, you let me know, we adjust. And can you plan dental work? Yes, you just want to make sure to let me know and make sure your dentist is aware that you're using a medical device that uses electrical stimulation. It shouldn't be a problem, but it's a good idea to just keep everybody on the same page. Okay, so now I will take more questions. We talked about a lot. So like I said, any questions you might have on Lenire, tinnitus treatment in general, literally anything that we talked about tonight, the time is now yours. Susan.
Josh, I have trigeminal neuralgia. So I probably do not qualify.
You are
It is
correct.
medicated, but
Yeah.
yeah.
So, yeah, so there are a few contraindications for Lenire, a few things that we have not talked about. So if you have trigeminal neuralgia, which is like nerve pain associated with your face, head, jaw, or neck, that is a contraindication. There's potential that if we start using electrical stimulation, it could make that worse. Yeah, so if you have trigeminal neuralgia, you're not the best candidate for Lenire. We'd start looking at some other things. Great question, sorry that.
I know.
And while we're talking about that, so some of the other things that we'd be concerned about and want to make sure that we're aware of. So if you have a pacemaker or any other type of electric implant, you'd want to let me know. And not to say that it totally negates the possibility of being able to use Lenire, but we'd have to get medical clearance from your cardiologist or whoever it is that specializes with the implant that you have. If you have a history of seizures or epilepsy, you may want to look at something else instead of Lenire as well. Unless they're really well under control, then we can talk with a neurologist and make sure that they feel that it would be safe. We just won't want to jump on board really. If you're pregnant or expecting to become pregnant, which I know I'm not, but that's not, we just don't have enough data. We want to make sure that we're not recommending Lenire in that case. Another situation is if you have oral piercings or sores or pain in your mouth that is unresolved. That's something we have to look into. And then the last thing is if you've ever been diagnosed with Meniere's disease. That's something that it's not necessarily a deal breaker, but we got to do some digging to find out if it's a good idea for Lenire.
What was that deal with what disease?
Meniere's. Oh, it's a disease that makes you really dizzy. And you have tinnitus as well, and sometimes hearing loss with that. Really not a fun disease to have. Yeah.
So what all do they do to check that to make sure? Because I have had the whole thing.
Okay.
But I
Yeah.
went to physical therapy to work on
Okay. Oh, so you're asking specifically about Meniere's?
yeah, because they said I didn't have it, but
Yeah.
I do have some hearing loss.
Okay.
Probably from music notice younger.
Yeah. So that's something that I would help investigate.
I'm curious.
Yeah, there's some testing that we have to do, and sometimes we have to be involved with ear, nose, and throat specialists. And I have one that is a little bit more ear specific, that is good at helping make
That's where
sure.
I went to.
Oh, did you?
Yeah.
Okay. If you've seen an ENT and they didn't think you had Meniere's, it's probably a safe bet.
I did have some ear pain as well, so now I'm
Okay.
wearing hearing aids and they, the hearing specialist should wear masks.
Okay,
And
yeah,
that, it helps during the day,
yeah.
but at night when I take the hearing aids on, it's like, man, I sleep well.
That's good.
Sleeping, so.
Yeah. And that's kind of one of the things that Lenire shines with is especially people who have trouble with their tinnitus at night. It's impacting sleep. This is something that's helpful because you don't have to wear it or use it at night for it to help. Yeah. Yeah.
Is there any credence to it goes away at night? Because I don't remember having it at night.
That's
It
good.
doesn't- It doesn't wake me up or anything. Is it still there? I just don't know it, or?
It probably, so what I would say is that the cause of it, excuse me, I've been talking too much. The cause of it is still probably there. Honestly, it's a good thing if you don't notice it at night, that's great. I would rather have that than the alternative. The cause is still probably there, whether the tinnitus is there at night or notice it or not, yeah, it may not.
So is it considered a lifelong treatment or you take the initial year? If it diminishes your tinnitus and you can back off? Or-
Right. Yep.
So
Yeah.
It's an intermittent, you're
Yeah.
stuck with it. It never makes it go away totally.
Right, so it's unlikely to say that it's going to just make the ringing go away. What is more realistic is to say, if your tinnitus, if you were to put it on a scale of 1 to 10 in severity, and let's say your average is like an 8, the hope is that we can bring that down to like a 3 or something that's more manageable, where it's not impacting daily aspects of your life. From what I've heard from the patients that have finished their treatments, they say that they feel like it just doesn't bother them anymore. They might notice that it's there. They may not even think about whether they have it anymore. But if they stop to think about it, they'll notice it's there, but it just doesn't really take up mental weight at all throughout the day. Like it used to.
Yeah, see, mine started with initial ringing. I probably started wearing earplugs too late in the game.
Okay, yeah.
But then I had the schwannoma around the nerve
Okay,
and got talked into the cyberknife procedure
yeah.
down there at Frontier.
God,
And I went out to Washington Medical Center. And I can't remember his name now, but he's like the world's
yeah, top dog.
premier.
Yeah,
And he said they never should use a cyberknife because the tumor was like 3.5 by 4.5 by 5, triangular wrapped around the cord. And the cyberknife did, its overshoot because it can only focus on 4. So that's, in fact, even in my records, I probably got collateral damage in there. Yeah, it's like it's so loud.
that's wow.
And if I do hearing aids, it amplifies it.
Does it? Yeah,
And then driving, if I do a long run of driving, then
yeah.
I mean, I gotta wind down for, usually hoping I'm really tired, but it's just even more amplified.
Right.
But yeah, and like a room like this isn't bad. Your
Yeah.
voice carries good, your voice doesn't. So I mean, I can hear, but I get in a larger auditorium or a real good outdoor setting, and
It starts
yeah,
screaming.
and then I've got 2 kids, 11 and 9.
Okay,
And when they were like my youngest, I could not. He had, a cute little lisp or mumble.
yeah,
And it was tough hearing them.
yeah, I see. So you're, not to put you on the spot, you're somebody that I would say you probably want to do some testing to figure out what might be best. It depends on what we see in terms of how well both ears are working, whether Lenire would be feasible. But there's some other things that we could do that would, even if Lenire is not an option, that may be beneficial.
Yeah, but I would think that if the idea of Lenire is to revitalize your hair, your
Yeah.
sensors, and your brain to get that signal going again, then
Yeah. It just depends on how severe the loss is in that ear. You hear anything from it out of that ear? Can we keep talking? Okay, I'll keep talking.
mumbling.
Okay, so you hear a
Yeah,
little
I
bit.
mean, it's.
Yeah,
And if I use the hearing aids, it helps, but.
Yeah.
It really, it depends on who's speaking.
yeah, gotcha. Yeah,
So
so
like now I'm struggling to hear you, so I turn to my left ear because that's a good ear. But
yeah, so it will depend pretty heavily on how much hearing you have left, if it's feasible.
It's below, it's like 40%.
Okay,
Yeah. And that was, I don't know, Raider was trying to do the sound, and he said, you got so much noise going on, I can't even come up with sound to mask. I mean, at one time before they did the fiber night, it was like a dolphin, the clip.
okay,
And I mean, I counted at one time, I was thinking 8 different noises,
Right.
variations of it.
uh,
Where now it's just a solid amplified
gotcha.
solid tone.
That's tough.
Yeah.
Yeah. Yeah, I think there's some things we could explore though. Yours is just a little bit more unique. I think I saw, did you have a question?
Yeah, so you said that this isn't covered by insurance, but there's other treatments that are,
Yes.
so that's something that could be looked at on the financial side of it.
Right. Yeah, for sure. Yeah, so some of the things that we look into are sound therapy. So like I said, that was kind of the previous gold standard. And we know it's effective for a lot of people. There's different ways that we can incorporate sound therapy, and some of it depends on whether you have hearing loss or not. But I have a few patients right now that they decided not to move forward with Lenire for one reason or another. And we've tried sound therapy and they have felt like it's been helpful. I've had a few where they felt like it wasn't, but sound therapy is actually something we can try without charging first. There's actually a way that we can trial it. If it works, we move forward with it. If not, then there's no harm if we try it. Yeah.
You say you work with the VA?
We do, yeah. Yeah, so we're community care providers, so to kind of get the ball rolling and to have the VA cover it is, you just have to get an authorization to come see us in our clinic, and then we can take care of the rest.
Now, do you have to get the authorization or do I?
Yeah, so they require that you call, they wanna know that it's your choice coming to the clinic, and that we're not soliciting it. But I actually have a phone number that you can call, and it gets you right to the authorization department. And so you just say, hey, I'd like to go see hearing and speech connection for my tinnitus. And then once we have that authorization from them, we take care of the rest.
I might get that from you.
That might be a good idea. Yeah, makes it easy.
I would enjoy that as well.
Yeah, are you a veteran?
Yeah.
Okay, yeah, that'd be perfect. That's basically.
I go to an eye doctor, doing clinic, and they have to authorize. And I
Okay.
say the authorization,
Gotcha.
that's why I asked.
Yeah, if you've come to our clinic before and they have previously set an authorization with us, then we're able to suggest or request it. In some cases, but typically the first one they have you. Yes.
Okay.
Yeah.
I might get that.
Okay. Now, full transparency with the VA situation. So it sounds like we have a few people in here that this would apply to. So to get Lenire, we have a little bump in the road. The VA has said, yes, we can get it for veterans. It's totally approved. Now, how it works is when I make a recommendation through community care, I have to sign off on the device I'm requesting or the type of treatment I'm requesting. And when it comes to Lenire, it also has to be signed off by the, either the durable medical equipment department or the audiology department. And we have had a little issue with the funding side of the audiology department. So it means there is sometimes a little bit of a hang up, but it's something that I'm anticipating will get better. So just, yeah, we kind of have to take it on a case by case basis, but like other VAs, you can walk in and get Lenire today. So I would imagine we're not far behind that. Being in Montana, we sometimes do fall a little behind the other clinics. So just a heads up, we're working on it, but we can still likely help.
But they help with, like, if you gonna check other things out before you do that.
Yeah, all of the other stuff that we talked about, they cover. It's just the Lenire because it's so new. Like it just recently got VA approval just a few months back. So still a little bit new. I think some of those hiccups will kind of wash through as we get more familiar with it. But yes, nothing with the VA is typically easy. Yeah. Any other questions at all?
So that unit, is that yours once you pay that? Or
Yeah, okay, yes, good question. Yeah, we haven't talked about that. So because of the type of FDA approval that Lenire has, it has the same type of approval as like a CPAP machine or a breast pump, which I have learned that once you use it, you cannot return it. So this is something that we only want to do if we are really, really committed and know that you're a good candidate for it. The other treatment options that we have are not like that. they don't have the same type of FDA approval that Lenire does, where it's really, really stringent. But yes, so that's something to definitely be aware of.
But would it always work if you needed it again, say a year down? The road, would it still work?
Yes, for sure. Yeah, you can use it for the lifetime of the device. In our clinic, we've had Lenire for about a year. We were on a wait list for 2 years to get it after the FDA approval. So there are some of the bigger tinnitus research centers where they've had it for a few years now. They have had patients where typically they stop somewhere between 3 and 12 months. And then they've told me that they've had patients that have, they'll feel like they're having kind of a rough week and they just need kind of a touch up. They'll start using it for a week or a month or so and then put it back on the shelf for when they need it next.
The reason why I asked that is she's had multiple surgeries on her foot, so they prescribe an electrical stimulation
Okay.
device.
Yeah,
So we and the insurance paid for it, but after 15 months, the system, I don't know how they do it, but they shut it down, so it no longer works. So it's like you buy something and then they take it away.
yeah, it's not like that, thankfully. Yeah. Okay, any other questions at all?
Would I get rid of my hearing aids then if I was to do something like that?
Good question. So,
I just don't like wearing them. I don't,
Yeah.
they just, I mean, I don't know.
You have to.
Yeah.
so So typically what we know from research is that patients who also use hearing aids at the same time tend to have much better success with Lenire. So I typically encourage continuing to use the hearing aids. It keeps those nerve pathways active long-term. If your tinnitus, if your hearing loss was really, really mild or not present really to any significant degree, then yeah, the hope would be to get away from having to use the hearing aids all the time. But if you have hearing loss, then we may want to keep using both. Yeah.
But not at the same time.
Not at the same time though, yeah.
So you take the hearing aids out,
Correct. Yeah, when you're doing the linear treatment, take hearing aids
because
out.
without my hearing aids in my, it's so bad I can't stand it.
Okay, yeah, and that's
When I go to sleep, I fall asleep, I don't hear it anymore, so it
that's
doesn't
good.
bother me. But as soon as I wake up,
It's back.
it's back.
That's the way she is, yeah.
But I've had it since I was a little kid, since I've been 4 years old.
Okay.
Oh.
And it's just progressively getting worse and worse and the older I get.
So you've had it 20 years now, right?
Oh, no. 20 years, thank you. Thank you.
Okay, any other?
19 really, to be honest.
Okay, yeah. Any other last questions before we wrap up? Okay, so we are, just to wrap up, we're gonna do the door prices really quick. This will just take a minute. If any of you are interested in, even if it's not Lenire, even if you feel like you want to explore some of those other options, we're happy to schedule you. We have one of my assistants here who's outside in the hallway, I think. Yeah. So she can schedule you if you would like. If you schedule for a tinnitus evaluation and end up deciding to get Lenire, if you schedule tonight, $250 comes off the total price. Really though, no rush. If you need to kind of think on it, I do typically recommend we at least do an evaluation. By doing an evaluation, you're not necessarily saying that you want to or need to do anything, but it gives me more information about what your specific circumstances are. We can make appropriate recommendations, and then you can decide from there. But my hope is that we can help you. If you've got tinnitus, we've had really, really good success with a lot of these things we've talked about, but especially Lenire. If it's going to be helpful for you, I'd love to do it. If we need to look at something else, that's okay too. So if you want to schedule, talk to Quinta on your way out. If you need more information from me or a business card or anything like that, just let me know. And then we'll do the prizes. So